We are now on the record. Today is November 22nd, 2017. My name is Daniel Herbert, videographer with State Shorthand Reporting Services, Oakhurst, New Jersey. We are here to take the videotape deposition of Dr. Stephen Cook in the matter of Weed versus Thomas, which is being held in the Met. This matter is being heard in the Superior Court of New Jersey, Law Division, Monmouth County, docket number 258-15. Counsel will now please state their appearance for the record.
Eric Miller, law firm of Chabelle and Many, for the plaintiff Vicky Weed.
Good morning, Patricia Adams, Campbell, Foley, Delano, and Adams, representing Celeste Thomas.
The court reporter Susan Bischoff will now swear in the witness, and you may proceed.
Please raise your right hand. Do you swear or affirm that testimony you're about to give will be the truth, the whole truth, and nothing but the truth?
I do.
Thank you. Can you state your name for the record, please?
Stephen S. Cook.
Thank you, doctor.
Good morning, Dr. Cook.
Good morning.
You had occasion to perform an independent medical evaluation of Vicky Weed at my request?
Yes.
Okay. And doctor, you rendered an initial report, and then after being sent additional records, a supplemental report?
Correct.
Do you have those reports with you here today?
I do have them in front of me.
Okay. Doctor, if at any time during your testimony you feel the need to refer to either of your reports, please feel free to do so. Just indicate that's what you're doing, okay?
Will do.
Okay. Now, doctor, before you begin your testimony regarding the substance of your evaluation, we need to go through your qualifications and request the court qualify you as an expert witness. Can you please tell the court the nature and location of your educational training?
I had an undergraduate degree at Princeton University in 1966. I went in the service and then graduated from Rutgers Medical School in 1976, completed internship and residency at the National Naval Medical Center, Bethesda, Maryland in 1982 in orthopedics. Had a fellowship training experience at Case Western Reserve and in Cleveland, Ohio with Henry Bowman, and I ran the spine service at Bethesda Naval Hospital until leaving in 1985, active duty in the Navy, and joining University Orthopedics with Joseph Sawatsky here in New Brunswick in 1985, for which I've been full-time partner until December 31st of 2016. I am now out of active orthopedic practice, except for what I'm doing now as a witness.
And would that be more or less consulting work on
Correct.
Patients that you didn't treat?
Correct.
Okay. Now let's talk for a little bit about your experience specifically as it refers to spine cases. Was that the bulk of your private practice?
Approximately 20% of my practice was dealing with spinal diseases of the cervical spine, thoracic and lumbar spines, tumors, trauma, degenerative disease, and so forth. And we all covered a certain amount of trauma. The rest of general orthopedics as part of our association with the partnership.
Okay. During the course of your affiliation with University of Orthopedics, what hospitals did you have privileges at?
Had privileges at Robert Wood Johnson University Hospital, St. Peter's University Hospital, and at one point Princeton Medical Center at Princeton, and for a brief period Jersey Shore Medical Center.
Okay. Doctor, was there a period of time that you were performing spine surgeries on a regular basis?
Correct, from 1985 till the end of 2016.
Okay. And can you give us a sense of approximately how many spine cases you would do on an annual basis?
Well, we were a team, and we would probably do close to 300 to 400 a year.
You and who else?
My two partners when I finished, which were Dr. Matt McDonald and Dr. Gino Chiappetta.
Okay. Now, doctor, as of the end of 2016, you've stopped treating patients.
Correct.
Okay. And you now do review of cases that are sent to you by attorneys and other parties?
Correct.
Okay. And do you do that on a full-time basis?
No.
Okay. Doctor, are you board certified in orthopedic surgery?
Correct.
Can you just give the jury a brief sense of what that means and when you achieved that certification?
I was board certified in 1983 through the Board of Orthopedics, which is an oral examination and a written examination.
Okay. And did you maintain that on a current basis?
Well, I don't have to take updatings because I was grandfathered, but yes, it's been active as long as I was practicing.
And did you could do your continuing medical education requirements as the time went on after you were board certified and you continued your practice?
Yes.
Did some of those include training in reading and utilizing MRI studies of the cervical and lumbar spine?
Well, it's part of our nature. Certainly we get involved in understanding, especially MRIs. I did that as a combined conference with the radiology department here in New Brunswick. We had a conference every Friday when MRI first came out. But obviously the reading x-rays and MRIs is our language, so obviously we have to be capable and competent at it.
Okay. Is that something that you ordered on a regular basis for your patients and read and relied upon on a regular basis?
Yes.
Now, doctor, did you ever have any teaching responsibilities for younger doctors?
Yes, we ran a residency program and we also had some conferences with medical students. So I was associate professor of orthopedics at Robert Wood Johnson University Hospital.
You said we. Who do you mean by we?
Well, all of my partners and I, we were all
Okay.
responsible for running the residency program.
Do you still maintain a medical license in New Jersey?
Yes.
Okay. At this point, I would like to offer Dr. Cook as an expert in orthopedic surgery.
No objection.
Thank you, doctor. If we can refer to the initial report that you did, I see that it's dated April 19, 2016.
Correct.
You had occasion to examine Ms. Weed on April 14, 2016 and authored this report.
Correct.
Can you just give the jury a brief idea of what your normal process was at that time for reviewing cases that were sent to you for evaluation purposes?
Usually this is an ExamWorks request and they'll send a pretty thick file, usually an inch or two of records. I may or may not be able to get through the records before I see the claimant that they want me to review. Most of the time I'm able to get through the records so I have some idea of what's going on. And then the claimant will present to our office for an examination one-on-one with me in an examining room where I try and figure out what their story is and what the issues were and what their physical and social problems might be related to whatever injury. Then I'll do a physical examination, and then if they bring any imaging studies with them, I will usually put them on the computer and we'll review them with in front of the claimant so they understand that what I'm looking at. And then afterwards, they'll be discharged from the office and I will do the report.
Doctor, you mentioned a moment ago that you think this exam was arranged through ExamWorks. What is ExamWorks?
ExamWorks is just a facility, as I understand it, that will coordinate all the paperwork and the requests of lawyers to evaluate a claimant, and then they had a contract with our office for not only spine but all kinds of other orthopedic issues.
Okay. Now, doctor, during the course of your career, would you also have occasion to testify on behalf of patients of your office who were plaintiffs in cases?
Yes, I have. I've been on both sides of the equation.
And in those cases, were you testifying with reference to treatment that you rendered to the person?
Not my patients per se. These would be patients or people that I've not treated.
Okay. So let me ask the question in two different ways. Did you testify on behalf of people that you treated who were also plaintiffs in cases?
Not that I can recall offhand.
Did you testify on behalf of plaintiffs that were sent to you for evaluation by their own attorneys?
Yes.
Okay. And do you still do that sometimes?
I do. It's not as frequent, obviously, as defense, but
Okay.
I do it.
Okay. Now, doctor, let's turn to your report. Do you give the person an opportunity to tell you in their own words basically the course of events from their accident leading to the present?
Absolutely, that's the most critical part of the evaluation, because you can understand their perception of what went on, what their memory is maybe, and related to what the actual reports might be, and also you read their body language and understand, get an understanding of how this issue may have affected them, and how they went about with treatment and so forth. So the
What-
interview is very important.
What understanding did you gain from Ms. Weed's interview?
Well, with her, it was a little more difficult because she had a poor understanding of what she was talking about. So right away, I sort of had a problem trying to get her to describe exactly what her problems were, what the injuries were. In one instance, she described that she'd had 11 bunion or Morton's neuromas excisions from her feet, when it was kind of a little unusual, since Morton's neuromas usually don't occur maybe more than once or twice on a foot. So there were little issues of that nature, and
Okay.
the examination was kind of unusual.
Did she tell you what her present complaints were that she attributed to the accident?
Well, she had sort of global complaints of neck pain, thoracic pain, and low back pain, and she claimed to be totally disabled and not able to do anything on a regular day or regular functional manner for everyday activities.
Did you have an understanding of what her condition was before this accident occurred?
At that time, I did not.
Just so we're clear, the accident that we're talking about occurred on August 12, 2013. So, and you were seeing her April of 2016.
Correct.
Did you, under the report that includes a heading past history, did you get an understanding in talking to her about her past history, what her condition was before the accident?
Well, she had considerable issues. She had a history of morbid obesity, which has its own problems, as all of us know. Crohn's disease, which is a significant disease of the bowel and can cause its own problems. Irritable bowel syndrome, depression, and she'd had, as I mentioned, multiple surgical procedures on her left foot.
Was she on any sort of disability before the accident?
She mentioned that she was on Social Security total disability.
And did you gain any other information about her social history that was relevant to your review?
Well, obviously, at that point she was unemployed, but she continued to smoke cigarettes, which is usually a significant aggravating factor for degenerative arthritic issues. Everybody recognizes that nicotine effect has a negative effect, process on how the body heals itself, so people tend to wear out more quickly if they continue smoking.
Okay. She was how old at the time that you saw her?
Let me see. Well, she was
You
born
noted,
in,
you noted it under your current complaint section.
okay. What did I say here? It should be right.
59?
59 would be right. I have her birth date on here. Some everybody has a different way of labeling these things.
Okay. And
She's 59, yes.
did your review include the records that were sent to you beforehand?
I have a review of the records that I did look at, and I have them labeled here, 1 through 9, and also radiographic studies, 1 through 5.
Okay. Doctor, did you do a physical exam the day that you saw her?
I did.
Can you please tell us what of importance you found when you examined her?
Well, the main issue obviously is her body type, which I've referred to. The most important thing for me is to see how people act when they're doing their usual things, like getting up, walking. I'll get somebody to stand up, walk on their heels and toes, which gives me a good idea of how everything's functioning. But she wouldn't get up. She had a roller walker with her, and she sort of was inappropriate how she would walk on her heels and toes. In fact, she wouldn't walk on her heels. She had an exaggerated response to light percussion. In other words, if you lightly tap her back, she would jump. And it was not very localized. I mean, it was everywhere. The motor testing I'll usually do when the claimant is sitting on a bench and do manual testing of the muscles. And she would give way on motor testing, which usually is a subjective event. Usually you can tell whether somebody's truly weak or whether they're just giving way.
What do you mean by that?
Well, if you test somebody's bicep, you can pull on the hand and you can usually see if they're firing, but if they're not and they're just doing this, that's giving way. And sometimes people give way because of a pain response, but you can usually determine whether it's just subjective giving way or whether it's truly a weakness or due to a pain response.
You said a moment ago that something that she did was inappropriate.
Well, that has to do with when she was trying to, hold on a second, let me see where you are here. The whole response to asking for someone to walk on the heels and toes is inappropriate.
What do you mean by that?
Well, she gives way, she exaggerates the response. She won't respond to you request them to walk on the heels and toes. If they truly are unable to get up on their heels or toes, you'll know that. But if they don't even try, then that would be inappropriate. So I was not able to document by my physical exam any obvious motor deficits or atrophy or physical impairment. There was this tremendous sort of overlay of how she presented that made it hard to really appreciate what was going on.
You also said a moment ago when you were talking about an aspect of your exam that her responses were generalized. And that because they were generalized, it was
it's holistic.
Just let me finish the question.
Yeah.
That it was indicating something to you. What does a generalized response, and what generalized response were you referring to?
If somebody has a specific problem with a joint issue, let's say in the spinal column someplace, they'll usually focalize their complaints to a certain area on the spine with referred pain pattern along the dermatome of that level. But in her case, she was everywhere, so everything hurt. And that doesn't help because it doesn't give you any indication of a specific problem.
Can I back you up a second and ask you to explain what you mean by referred pain to a dermatome?
Well, each level of the spinal column, every disc level, has associated with it an exiting nerve root. And the nerve root, if the nerve root's irritated or if the sensory fibers of the nerve root are irritated because of the joint, you will get pain along the dermatome of that nerve. So typically, if someone has an L4, L5 disc herniation, the referred pain pattern is along the L5 nerve root, which would be coming into the buttock, the lateral part of the leg, down into the top of the foot. So that's a clear-cut dermatome for that level. L5S1 would be more into the buttock and down into the calf, and L4 nerve root would be in the anterior thigh, so forth. And that's true for the cervical spine and for the lumbar spine. And even in the thoracic will give you a dermatome according to the level.
Doctor, as part of your review, you looked at her answers to interrogatories with attached medical records from her treating doctors.
Correct.
Okay. And you mentioned earlier looking at diagnostic studies that were present at the time of her evaluation.
Correct.
Can you share with us, Doctor, what studies you looked at and tell us what, if any of them, showed anything relevant to you as far as your review is concerned?
Well, I personally reviewed the following radiographic images: X-rays of the lumbar spine performed on the 19th of September 2013. Approximately 4 weeks after her injury. These X-rays didn't have a grid, which means it's a technique for how you take lumbar films. The grid will get rid of a lot of the, what would you call it, the spraying of the X-ray beam, so it's not very clear. So these films were very poor quality. They didn't really show me very much. I reviewed an MRI of the lumbar spine performed at University of Radiology, dated 6 November 2013.
Do you have that with you today, Doctor?
Is that one, this one here? Yes. Okay.
Okay. And you also reviewed a cervical MRI study of the same day?
Correct.
Okay.
And we have that here.
I see that you have the cervical MRI study up on your screen.
Correct.
Can we focus our attention to that first, since that's the one you already have queued up, and I'll ask the videographer to go off the video record and focus his camera on the film.
Okay.
Time is now 9:55, going off the video record. Time is now 9:57, back on the video record.
Doctor, we have here the cervical MRI images of 11/6/13 on our laptop. Can you focus your attention to those, doctor, and explain to the court and the jury what, if anything, of importance you saw when you looked at that film?
Well, the film generally looked to see how the spinal cord is dealing with its location within the spinal canal. And in this case, the spinal cord is nice and clear. There's no compression of the spinal cord. There looks like there's a chronic disc bulge or herniation at the C3, C4 level, which you can see as sort of a dark bulge. It doesn't seem to be pushing on the spinal cord. That obviously has been there for quite a while. I can't tell you how many years, but it's obviously it's a chronic condition.
Doctor, are you able to point to that for us?
I can. It's this right there. Okay. So the issue comes, it depends on how a radiologist will interpret the findings. They might say large disc herniation. Some people say disc bulge. Other people say chronic dehydrated disc. There's a lot of different terms. But the important part in interpreting the film is, does the disc herniation cause any kind of neurologic compression? And in this case, the spinal cord is clear. There's no compression of the spinal cord, and this is not a clinically significant finding.
You said a moment ago when you discussed the finding at C3-4, you used the word chronic. What do you mean by that?
That is, the condition has been around. It's not likely to have been a response from a trauma or an injury, that sort of thing.
And how is it you can tell that by looking at the study?
Because of the dehydrated content of the disc is dark throughout. Usually if it's an acute herniation, there'll be high signal, which is usually edema within the disc, indicating an acute herniation.
It looks like this study was done less than 2 months after the accident happened.
Just slightly more than a month.
Okay. With that, doctor, knowing that time lapse between the accident and when the study was done, does that reinforce your opinion as far as the chronic nature of that disc?
Correct.
Okay. Is that a finding that you would expect to have manifested itself in that brief period of time from the accident to the study?
No, and I also know that 30% of the adult population have significant disc herniations that have no clinical findings at all, so this is not an unusual finding.
Did you also review a MRI study of the lumbar spine done the same day?
I did, and if you give me a second, I can put that up on the screen.
Okay. If we could go off the video record so the doctor can get us to that image.
Time is now 10 o'clock, going off the video record. Time is now 10:05, back on the video record.
Doctor, can you refer to your report, please, and share with us what you saw when you looked at the images of her lumbar spine that were taken on November 6, 2013?
Basically, the lumbar spine showed that the spinal canal was open, that there was no significant nerve compression. I also noted that there was darkening of every disc level of the lumbar spine, which is indicative of dehydration and a degenerative process. I did not see any evidence of an acute injury or acute process that would indicate a recent trauma had occurred.
Okay. Now, doctor, was she still in active treatment for this accident at the time you saw her?
In active treatment? No, I don't know if I have responded to that. I don't know. I don't have any information that way.
You don't have any information that she was still treating?
Correct.
Doctor, based on your review of the records and review of the films and examination and history of Ms. Weed, did you come to a diagnosis within a reasonable degree of medical probability of any injury she may have sustained as a result of the subject accident?
Well, I did, and I would refer back to one of the reviews of the police accident report, which is a very important piece of information for me to understand the energy level of the injury. And the accident report indicated moderate to low injury or low impact energy,
I'm going to object.
and that
Time is now 10:07, going on the video record. Time is now 10:08, back on the video record.
Now, doctor, based on your history that you took from Ms. Weed, did you have an understanding from her, her perception of how the accident happened and the nature of impact?
I did.
Okay. And what was your understanding from Ms. Weed?
Well, that she was involved in a motor vehicle collision, that she sought medical attention afterwards, and that's about all I got from her.
Okay. If you look back to your history section, did you have an understanding from her whether this was a high-speed impact or a low-speed impact?
It was a low-speed impact.
Okay. Now, based on everything you knew from her history and from reviewing the various records and doing an exam and looking at the films, did you come to a diagnosis within a reasonable degree of medical probability of any injury she may have sustained in the subject accident?
I did, and my diagnosis would be cervical spondylosis and lumbar spondylosis that is interpreted as pre-existing degenerative arthritis of the neck and lumbar spine. She had most likely some temporary aggravation of these conditions at the time of her accident, and it would be my opinion that the aggravation factors would have long since resolved, usually within 6 months to 12 months at the latest, and that at the time of my examination I saw significant overlay and symptom magnification and no evidence of an injury or physical impairment that I could relate to the motor vehicle collision of 12 August 2013.
Just so we're clear, doctor, did you come to a conclusion if Ms. Weed sustained any injury of a permanent nature?
Correct. I did not see anything that would be permanent.
Now, that was after you had those materials at the time of her exam. There came a point in time in 2017 where my office sent to you additional records. Is that right?
Correct.
And did you prepare a supplemental report after you reviewed those additional records?
I did.
And just so the jury understands, can you give a brief sense of what those records were that you reviewed?
These records involved medical exposures to treatment and conditions that existed prior to her accident, going back as far as 2005, and indicated that she had visited the emergency room on multiple occasions for a lot of other issues, medical issues and so forth. And I reviewed some disability forms which indicated that she had been on total disability for a considerable period of time for the same sort of complaints of neck pain, thoracic